Hello everybody and welcome to this OrthoNinja Academy session on ballistic injuries, and in the UK, and my colleague here with me, Shariff, was a colleague of mine in Manchester, now working in Jeddah in the Kingdom of Saudi Arabia. And some things you need to know about Mr. Shariff is that he came very highly recommended to Manchester. He had done the fellowship with Meissen, so he's very well qualified. He was a very popular and knowledgeable consultant in Manchester, and he was a great colleague and a great teacher on courses. So we appear to have lost him. Raheel, can you hear me?
Amer, I can hear you. I seem to have lost you on camera, but thank you very much for those kind words. I'm pretty excited.
So
looking forward to this
great
session as well. We seem to be having slight issues with the IT tech here because I can't seem to see you on camera, but I can hear you. So maybe I will, whilst I'm presenting, you can log out and log back in, or vice versa if we lose each other. And I'm quite happy to see a few friendly faces from England in the attendees today. Quite a few of the ones from back in Manchester. So hello to everyone, both in Saudi and in Manchester. Great. Carry on, Amer.
So by going through a case just to sort of set the scene and to give you an idea of the sort of the subject material that we're going to cover, and in order to try and sort of facilitate everyone's involvement, what we'd like to do is to run some polls, everyone just to give their opinion, and those will be running at the right-hand side of your screen. And we don't know who's answered which question in whichever way, and it's entirely anonymous. And what we want is for people just to be honest, to give their opinion, and then we'll go through the answers. So there's no embarrassment or anything like that. We just want you to take part. So would you like to start off with the first case then?
Sure, Amer. So let's get started with a case, and hopefully some of the questions which are going to come up in this case are going to give us a flavor of things to come in Amer's talk. I'm quite looking forward to certain things like primary injuries, secondary injuries, quaternary injuries. What is the velocity of a bullet? How does that impact injuries and things like that, which Amer, who has a large amount of experience in these kinds of combat injuries, is going to talk to us about today. So here's our first case. We've got a 23-year-old who was shot in his right leg, as they are. It was an isolated injury, and this was his clinical picture and his x-ray. He can't obviously bear weight, and we've been in the emergency room, we've done the ATLS protocol, and we are presented with this. So as we can see, this is a small, possibly a 1 centimeter wound on the anteromedial aspect of the shin. And the first question which we're going to pose to you today, and we'd like you to answer, is bullet wounds. Bullets are inherently sterile because of the amount of heat that they generate. And wounds are also inherently sterile because the bullet sterilizes the wound. Is this statement true or false? So the poll has come up on the right-hand side of your screen. For some of you who possibly have that section closed, just click on the top right and you'll start seeing the polls. And we'd like you to answer that question. Amer, what are your thoughts on this, whilst we give the audience a chance to answer this question?
I think it's a really interesting question because it's something that you hear quite a lot. Now, I've been all these books behind me. A lot of these are on military surgery, and I found this book. I don't know if you can see me, but I found this book from 1908. And
no, that's not how old you are, right?
Repeat. Oh, that's harsh. Harsh.
God.
I'd always thought that the vast majority of people have chosen false because these wounds are not sterile. And what's interesting is that I always thought that was from Hollywood. That was because people had watched too many movies. But this book from 1908, so it's pre-World War I, it states bullet wounds are clean. But then in the next paragraph, it says most of the people who die in the aftermath, not dying immediately from their wounds, but they die in the next month or two, they die from infection. So I think really there's the answer, that these wounds are not sterile, and if we don't treat them appropriately, then it's going to risk that it's going to kill our patients.
Absolutely. And it's important. This is the idea of having this kind of a session where we're trying to collaborate and bring about best practices from across the world. In England, we've always been taught that gunshot wounds, open fractures, well, open fractures is a different kettle, but gunshot wounds or bullet injuries are dirty. We've got to wash them out, debride them, and then the antibiotics kick in as well. Now, there was a paper recently in Injury, which was presented this year, published this year, which stated otherwise. This was the experience from Joburg and Cape Town, where in South Africa, we know there's a huge amount of gun violence. And they seem to suggest that their guidelines are diametrically opposite to what the British guidelines are, which is if it's a gunshot wound and it's essentially just hit the soft tissues and missed the bone, or hit a section of the bone, just a unicortical fracture as they call it, and most of the bone is, the structure is intact, you don't necessarily need to wash these out. What do you have to say about that?
I think obviously they've got a great deal of experience in South Africa with gunshot injuries, but I would still follow the UK guidance for my practice, because because they're so experienced, they might be able to get better results. But in my hands and following UK practice, what I'd be worried about is that 10% of patients who are going to get an infection. So I would be cautious. I think it's better to, for me personally in my practice, it's better to be cautious and to try and play it safe, because I don't want to rely on luck to give my patients the best outcome. I'd rather that I had something to do with their outcome.
Okay, great. Let's move on and see. This wound here is 1 centimeter wide. Okay. As per the Gustello-Anderson classification, we would grade this as a 1, a 2, or a 3. So we're posing this question to you. We'd like you to answer this. What do you think, Amer? Amer, we seem to be losing you back and forth on the screen, just as possibly the. Just check your streaming speed, but we can hear you fine.
Yeah.
Carry on, but just give you a heads up.
I don't think I need to log out. I'm just
no,
we'll
carry
just
on,
carry on. If you can hear me, that's fine.
So, Amer, what would you call this? Most of the audience here seems to say it's grade 3. 79% of the audience is calling this a grade 3 injury. As we know, the grading done post-debridement, as we discussed in the open fracture session last week. You'd agree with that? We've got 20% saying grade 1.
Absolutely.
How would you counter that argument that this is not a grade 1, and the majority of the audience has got this grade 3?
So I agree with the majority of the audience that Gustello-Anderson, although it talks about a grade 1 being 1 centimeter wound, that's if it's a gunshot injury, it's automatically a Gustello-Anderson 3 because of the high energy nature of the wounding, and because there's likely to be soft tissue stripping associated. If there's a broken bone, there will be soft tissue stripping as well, which is just not visible because of the size of the entry hole. So I think it's definitely a grade 3.
Okay, yeah, I think we all agree with that. So
Great.
Here's the next step in this saga. There are 2 wounds. There's one entry and one exit wound. How do we clean them? Do we clean the wound with a large syringe? So basically, do we just flush that wound from the entry or the exit wound out through the other side and then close the wound once all debris has been cleaned out? Do we clean these wounds with a large syringe and leave the wound open? And Amer, I think you're pushing that bowl across, right? And do we extend the wound, debriding any non-viable tissue, and then close that wound? Or do we extend the wound, debride non-viable tissue, remove any loose bone bits, and then leave that wound open. So those are our 4 options we have. And we're going to give you a moment to answer that. Amer, thoughts?
So, really, there are 2 questions here, aren't there? The first of all is, how are you going to lavage the wound? And the second question is, once you've cleaned it, is it safe to close that wound? In all the talk we had on open fractures last week, we discussed how it was necessary to extend a wound, to excise a wound, to debride it by opening up the bone like a shotgun.
Yeah.
Taking out any loose fragments. So I think, just flushing it with a syringe is really not an adequate way of cleaning the wound. So I discard the answers that involve just using a syringe. And then the second question is, should we close the wound? And we've already talked about how these wounds are inherently contaminated. So I wouldn't want to close a wound over potential contamination, because I'll just end up having to go back in and my patient's going to suffer more if they get an infection. So certainly for the first debridement, and probably second and third, I would leave the wound open again.
Yeah. So I think it's worth digressing here.
Looking at the poll.
You're going with 4, are you?
Sure.
Let's see what the audience seems to be answering.
Yeah, I'm going to go.
We've not got too many people who've answered this question just yet. They're probably mulling this over. We've got 27%. Oh, sorry. We've got about 15 answers here. 67% agree with you and going with 4, which is extend, debride, remove loose bits of bone, and leave it open. 25% seem to want to close the wound primarily. As Amer is saying, this is probably not a great idea, because these are high energy wounds. They'll have debris, micro and macro debris. Remember, parts of the bullet might be in there, bits of shrapnel, parts of clothing, which we may have missed at the first debridement, no matter how aggressive we've been. So it's always a good idea to sort of take your time, go back in for 24, 48 hours, depending on this wound, and get it cleaned up. It's worth probably digressing here, Amer, and just talking about the trajectory of the wound from an entry and exit wound point of view. So when we see an entry wound and an exit wound, it's probably worth in our mind's eye going through where that bullet might have, or that shrapnel, piece of shrapnel might have passed through. Has it gone through hollow viscous organs? And all these things sort of have to be looked at, because potentially you can have bullets that have pierced small bowel and then gone and lodged into the femur, in the thigh. Or they could have gone through large bowel and then gone and lodged in the pelvis or the femur. Is there a difference between the small bowel and large bowel? Because the flora is different. A large bowel wound by default is a contaminated wound. So these are all things which we might have to think about, isn't it? We seem to have... Amer, if you can hear us, I think you're having... Amer, you're having problems with your... Yeah, you're back on. Carry on.
Okay, so we're going to talk about this in the ballistic section of the talk, but essentially the bullets do tend to follow a true path, so they go in a straight line. So it's important to visualize what structures the bullet may have been through. And quite commonly, a military round will break up into several bits, and it's important that you try to identify different tracks that the fragments may have gone down.
Okay, so let's say we've done what most of the audience has suggested. We've aggressively debrided that wound. We can't see any more non-viable tissue. Everything looks healthy. How much contamination do you think remains in the wound? 1%, 5%, 10%, or 50%? So we're going to give you a moment to answer that, and let's see where we are at. So this again brings us back to the fact that it's probably best to have a second look. There's a bit of a hint there for all of you. It seems like 50% of the audience has answered so far. We're going to give them a moment. So that extended linear wound on the top picture there, that's gone along the fasciotomy lines. Just to reinforce to our colleagues that any wound that needs to be debrided, we connect it to the nearest fasciotomy line, and in this case, that's the posteromedial fasciotomy line that it's been connected to. So we've had most of the audience has answered. 50% are going with 50% risk of contamination. 47% or half are going with 10% contamination. So the right answer there is there's a 10% risk of contamination, even if you've been very aggressive in your wound debridement. Amer?
Absolutely. You know, I go with 10% as well, because no matter how good a surgeon you are, no matter how clean it looks, there will always be some contamination along tissue planes that you've missed and you won't be able to clean out. And quite often in wounds, what you find is that you will debride and you'll go back to what you think is healthy tissue. And then the second time you go into that wound, you will find that the tissue which looked healthy before, that surface is now necrosed. So you've actually got more necrotic tissue to debride away. And because it's necrotic, it's more likely to develop infection as well. So that's the basis that you're going to go back in and do a second or a third debridement, so that after the first debridement, you've got 10% left. After the second debridement, you've got 1% left. After a third debridement, you've got 0.1% of the contamination left.
Mr. Shoaib is going to go for gold here. This question is posed to him. What's the risk of osteomyelitis after your aggressive debridement?
Well, again, you know, even in the best of hands, you know, in the literature, the risk of osteomyelitis is about 10% for ballistic wounds.
10 points to Gryffindor there. Okay. Final question before we let Amer take over and give his talk. So we've done our debridement. We've given it a good, thorough clean. It looks nice and healthy now. How are we going to fix this definitively? Okay. Are we going to nail this? Are we going to put a medial plate? Are we going to put an anterolateral plate or a circular frame? So here are your options coming up. We'd like you to have a go at answering that. So remember, now the wound is clean. Okay. Amer, I know you swing both ways. You fix internally as well as you use circular frames. We're going to give the audience a moment to answer the question. And there is no right or wrong answer here to everyone. It's what works best in your hands. There is a slightly, there's a swing towards one favoring the other possibly. 50%, oh, we've got a tie here. We've got 50% saying that they're going to put a nail in here and 50% who want to frame. So this was a high energy injury. It was a gunshot wound. We've had to take it back to the operating room more than once to debride. In your hands, Amer, what would you do?
Well, if we just go through the answers, we've got a wound where we have soft tissue stripping, and we're also worried about infection. And if we were to apply a medial plate or an anterolateral plate, then I think that would involve a lot more soft tissue stripping, a lot more devascularization of the bone. So for that reason, I wouldn't go for those two options as a means of managing this particular type of injury. Now, it does depend on horses for courses, you know, what people think works best in their hands. I can say that I've seen a fair number of ballistic injuries that have been managed with intramedullary nails. And my concern from my experience is that if you're one of the 10% who has an infection, if you put an intramedullary nail down, then there's a risk that you're going to spread that infection up the long bone that the nail is in. And I would be concerned that there's a risk that I could actually make my patient worse by putting down an intramedullary nail, although that's a very common treatment and I've seen it done and it's worked and the patient's been fine. But because of my experience of having seen a lot of intramedullary nails getting infected after ballistic trauma, I would go for a circular frame.
Okay. Yeah.
The reason is that if you put a circular frame on that mechanic, at the same time you're not putting metal.
Okay, we seem to have lost
soft.
Okay, so I think what Amer
Can you hear me?
is saying is that, yes, we can hear you now. So basically, to summarize what you've just said, circular frames probably safer, but it depends, as you said, horses for courses, what works in your hands. But what the big take-home message here is, if all you have is a hammer, then everything you see is a nail. So that shouldn't necessarily be the case. If you think this fracture needs a circular frame, if you get that feeling and you don't frame, pass it on to someone who does, because you'll end up causing more damage to the patient by nailing it just because that's what we are comfortable doing. What about the literature, Amer, about using antibiotic impregnated nails? Do you think that has a role in these kinds of nasty injuries?
Well, in theory, if you have an antibiotic coated nail, then that should address this very problem of risking infection being transmitted along the nail. But what we do, there's nothing actually in the literature to definitively show that there's no infection. And one of my concerns is that if you have a coating on a nail, that coating might be very brittle, and when you're putting down a nail through a very narrow medullary cavity, we don't actually know what's going on underneath. So the coating may be being stripped off. Like I said, the circular frame still, even if an antibiotic nail was available.
Okay, great. So that's just a quick case we wanted to discuss with you before we hand over to Amer for a talk. Amer, can you hear us? Because you seem to be flitting in and out of the presentation.
I can hear you fine. Can you hear me?
So as long as we can hear you, we're good. We'll carry on. If at some point we lose you, I'm going to just message you so that you can log out and log back in again. Now, for those of you who don't know Amer Shoaib has a lot of experience with war injuries. He's served in the British Territorial Army. He's been in active combat zones in Bosnia. He's been in the Middle East as well. And he's very active with the use of frames, internal fixation, and has a large amount of experience, which we're looking forward to him sharing with us for this often complex and challenging group of injuries, which as civilian surgeons, not all of us have access to. I know there are a few military surgeons in the attendance audience today, and I'm sure you've got some thoughts. What I'd like you to do is any one of you, please use the chat option and ask the questions as we go along, and we'll direct it to our speaker. So Amer, over to you.
Okay, can you hear me?
We can hear you, we can't see you, but that's okay. Carry on, please.
That's fine. So thanks very much, Raheel. Raheel's hiding his light under a bushel here because Raheel was present in Manchester in 2017 when we had to respond to the Manchester Arena bomb. And I've got to say that there were a few surgeons that I was actually on call that day, so I was leading the orthopaedic response. And there were a few people that I called in, and number one on my list was Shariff, as well as Praveen Sada, who now works in India, and Anand Thebanesan, who still works in Manchester. So Raheel actually does know a fair bit about ballistic injuries, but I'm going to take you through what we might consider the rudiments. And the subject matter that we're going to cover is basically things like gunshot injuries from handguns and from rifles and from shotguns.
I think we need to address the elephant in the room. Before Mr. Shoaib carries on, he's just come off a war zone injury, so you see the cut on his above his eyebrow.
I had a tumble walking in the Lake District, so
we believe you, Mr. Shoaib.
Yeah, so I have to have a cut on my eyebrow. So we're going to talk about bomb injuries as well, and I'm specifically going to talk about my experience, not just from Manchester, but also from the Syrian civil war and Gaza as well. So that's what we're going to talk about. Now, it's a nasty business. Therefore, they're designed to injure and kill, to cause harm to other human beings. Now, there are laws laws for the way that people are supposed to behave in combat. They're called the laws of armed conflict, and there have been several treaties which are internationally sort of recognized for the humane conduct of the art of war. The problem is that when a war breaks out, the laws of armed conflict go out of the window and people behave very badly. So the first thing to do is probably to talk about bullets. So in your picture there, you should be able to see a cross section through a bullet. And this is actually a cartridge which contains the bullet at the front end. And the bullet is normally made out of lead, and it's covered with a copper nickel or steel coating. And then that sits within the cartridge. Now, at the bottom of the other end of the cartridge to the bullet is primer. So when you pull the trigger, the firing pin hits the cap, and that ignites the primer. When the primer is ignited, it causes a little explosion, and that causes the powder inside the bullet to explode. And when it's a chemical reaction, and it's the gases which are going to push the bullet out of the end of the cartridge down the barrel of a rifle or pistol, and as it comes out, the rifle this particular bullet, if it's got a full, it's called a full metal jacket, which is it's famous. If you want to know where the reference comes from, Stanley Kubrick. Mm-hmm. But full metal jacket is considered in war to be a legal round. Now, rounds, and they don't have a full coating of copper nickel or steel around the bullet, and they behave in a very different way. Now, you'll hear people talking about low velocity and high velocity injuries. That's perhaps a little bit of an old-fashioned way of describing them. We now tend to talk about the energy transfer. So how much energy gets transferred from the bullet to the body as it causes damage. So I suppose the next thing we need to ask you is, what's more important for the kinetic energy in a bullet? So the kinetic energy is the energy that is going to be transferred from the bullet into the flesh. What causes there to be more kinetic energy in the bullet? Is it the mass or is it the velocity?
So we're giving you that question is being pushed to yourselves. We're giving you a moment to answer that question. Amer, this boils down to physics, doesn't it?
Absolutely. We'll just give them a few more people who want to choose one of the answers. We're remaining fairly static in terms of number of answers now.
Yep.
So
we've had.
So you're absolutely right, Raheel. It's all about physics, and it's something that we've known for a long time. Kinetic energy is half mv squared. So it's.
Amer, may I suggest something whilst this slide is on? If you just don't mind just logging out and logging back in, because we seem to be losing you. I'll just carry on the discussion till you log back in. Is that okay?
Okay, I'll log out and come back in then.
Thank you. So as Amer was saying, it's all about the energy that is generated from a bullet. It's not the mass or the velocity, but in your exam scenario, for example, in the training programs, if you've got to pick one, it's the velocity, which is more.
Oh, can you see me now?
Because we can hear you now. I think you're just fantastic. Carry on.
I'm back in. Can you hear me?
We can hear you now. I think your connection is a bit tenuous, but we can carry on. It's fine.
Okay. So I've mentioned already that energy is half mv squared, and it's all to do with how fast the bullet is coming out of the muzzle. And so if you look at the two rounds in the bottom left-hand corner, the smaller one is a 2-2 round. So that's 0.22 of an inch, which is about just over 5.5 millimeters. And the second round, the much larger one, that's a different cartridge, but actually the size of the round is just over 5.5 millimeters, 5.56 bullets. Now, the interesting thing is that even though the bullets may caliber and the weight are much different, the reason for the different size is the amount of powder. So because of the greater amount of powder, it's able to velocities. Squared, it means that it's not just the speed, but also the energy that from the round, which is going to be that much higher. Now, it's not actually projecting very well, but the 9mm pistol is going to generate a speed of 353 meters per second, and the energy is 519 joules. If we look at a rifle, which has a smaller round at 7.62, which is fairly typical for an AK-47, then its speed is as it leaves the muzzle is 715 meters per second, and its energy is 2045 joules. Now, the M16 fires a 5.56 round, and the speed is more, 975 meters per second, but the energy is 1854. So even though it's a much smaller bullet, its speed, so with it, but the velocity is a little bit more on the final energy. So for what we're jacket, and just need to get up a video. So I don't know if you can help me here, Raheel, by putting up the video for the full metal jacket.
Yeah, okay.
So you can see the bullet coming in from the left-hand side of your screen, and it goes in a straight line, first of all. What it's doing is creating a cavity within the body. So let's go back to the presentation again. So
yeah, I'll do that in a moment. Sorry.
Oops, wrong one.
Yeah, give me one moment.
So that round, it tends to follow a straight path, first of all, and that's about sort of 12 to 15 centimeters. So the first 12 centimeters that bullet is within the body, it tends to go in a straight line. But as it is body, the bullet, although it a tumble, instead of going in a straight line, the resistance causes it to start going sideways. So it's going in the same direction, but it's going sideways, and it actually imparts a lot more energy to the body then. And what happens is that it creates a cavity within the body, and it first of all creates a temporary cavity, so it's much bigger, so it sort of creates a cavity which then collapses back down in on itself. So there's a temporary cavity and there's a permanent cavity, and that's all reflected in the energy sort of being transferred to the human body. Now, that was the full method.
So Amer, basically what you're telling us is that it's not the either the mass or the velocity, although velocity is a little more important for a bullet, or the caliber. It's the amount of energy that is dissipated within the body, depending on what structure it hits.
Absolutely.
Correct?
So if you have a bullet that goes through a part of your body, say your arm, that is less than 12, 15 centimeters long, it may go through your bone, but it will follow a straight path. If it stays in your body for more than 12 meters, then it will start to tumble, and you'll create this cav temperature as well. So, and that's when it's transferring a lot of its energy. So it's possible to have a low energy transfer if it goes through a part of the body that's less than 12 centimeters wide. Now we're going to move on to a different type of bullet. This is a semi-jacketed bullet, and this was developed by the British Raj in India. And as I said before, there were laws of armed conflict, and this type of bullet was deemed as being inhumane by the Hague Treaty, and it was banned immediately. But it's still quite widely used, and it's used in law enforcement, and in the US they call it home defense. We're going to have a look at the ballistics, and that will explain to you why the law enforcement authorities use it. So if we have a look at the next video.
Yeah, I'm going to bring that up to you
so
in a moment.
It should be. So,
So we saw that video there,
right.
of these jacketed.
Right. I didn't see that video. Is it possible to play it again?
Sure. Okay.
Right. So in this video, this is what the bullet looks like, and it's not got a cover. It's no copper and nickel over the end of the bullet, and then after it's been through the human body, that's what it looks like. So if you compare it to the full metal jacket, which broke up into two, this bullet has basically become completely flat. And the reason it's become completely flat is because it has transferred all its energy to the body. So there's as well. Have you seen that one already for the semi-jacketed?
The one where through the soap.
That's
bar.
right. Yeah. So
yeah.
Yeah.
Okay, I'm going to share that with you.
So
that's the one that's getting flattened out as it goes through the.
Absolutely. So what you can see with the semi-jacketed is that there's no small tunnel at the first 12 centimeters. It actually, as soon as it hits the body, it transfers all its energy and it creates a large temporary cavity. So it doesn't actually go all the way through as the full metal jacket round would do. And that's why it's used by law enforcement, so that it doesn't, if they shoot somebody, then it doesn't cause, the round isn't going to kill someone behind them. It's got more stopping power, and it's just going to stay within the first subject that it hits, rather than going through and causing damage to other people. So here's a good example. So this is a man who was shot in his chest, and you can see on the chest x-ray on the right middle of his chest. But what's really interesting is the CT scan on the left, and you can actually see the damage that this round has caused within his chest, going from front to back. So you can see that there has been some cavitation, and there's damage to the tissue of the lung, which is far wider than the track of the bullet. So this just indicates how much wider the damage is. And if you look at the CT slice from underneath, what you can see is the round, which is sitting next to the transverse process of the spine.
About there, yeah. Right at the bottom.
Absolutely, just at the very bottom there. So that bullet is sitting next to his spine. So let's have a think about this poll. If you have a bullet or shrapnel within the body, should we be taking it out? So
we're going to push that poll to you. So it's like that dictum in orthopedics, isn't it? There is a bone, I must fix it. There's a bit of shrapnel, should I take it out? So okay. The vast majority seem to be going with false. You don't need to take out shrapnel.
Yeah. And what do you think, Raheel?
So I'm in agreement. If you have shrapnel which is visible while you're debriding, you take it out and get rid of it. But we don't have to go in further, deeper and further. We might end up causing more damage. And particularly when it comes to shrapnel, it's not necessary to take it out. With bullets, could it be controversial? Or do the same laws apply?
Well, exactly the same. So if it's something that's visible and accessible, then we should be taking it out. But if it's buried somewhere and there's a risk that you're going to cause more damage by trying to retrieve it, then clearly it's not worth retrieving it. So that bullet was lying next to the transverse process, and the risk is that if we go in from the back to try and remove that, we're probably not going to achieve very much apart from cause more damage. So I would leave that alone.
Okay, so if you've got any questions in the audience, please feel free to post them in the chat box, and we will take them up as we go along.
Okay, so let's move on to the next. Now,
we discussed this, right, isn't it? Where the energy and the velocity.
That's right. But this is what I'm going to talk about in this slide is essentially what happens with a shotgun. So just like with a bullet, you can see that timer there, and there's powder, and there's also some wadding. But instead of having a bullet at the front, in this shotgun cartridge, we've got these little steel balls. So when the shotgun is fired, the powder is going to explode, and it's going to push out the wadding, and it's going to push out these the little ball bearings from the front of the shotgun, and sometimes even the cartridge itself can be ejected too. So you can. But
shall we have a look at the ballistic video on that?
Yeah. So if we look at the at very short range, the shotgun transfers a lot of energy. Is the video coming up?
Yeah, it was. I'm going to play that again. So this is oil, I take it. That's the video which is showing the dissipation of energy from a shotgun. And we can see there's a massive amount of cavitation occurring there.
Absolutely.
And spray.
It's not going to have that much energy because it's going to lose its energy fairly quickly, but at short distances, it's a massive amount of energy that could be transferred to the body. It can easily take off a body part or actually destroy the body tissue, so it's unrecognizable. So here's an example of a shotgun injury to a bone. So here we can see a femur, and you can see all the little ball bearings within the soft tissues, and you can see that there's a fracture. So the energy has been transferred to the bone, it's broken the bone, and that fracture is going all the way actually down to the metaphysis at the bottom of the femur. So, in terms of these penetrating injuries from rifles and shotguns, I think essentially the take-home messages are that, and that if we debride them, we're not going to get rid of 100% of the contamination. So it's essential that you don't close a ballistic wound on the first debridement. To protect the soft tissue, spanning the fracture with an external will actually stabilize the soft tissue as well as stabilizing the bone. Now, there are lots of controversial areas. So last week, when we talked about open fractures, you talked about the tug test, and you talked about how if a piece of bone was loose but it had soft tissue attachment, you'd leave it behind. With a ballistic injury, I'd perhaps be a bit more aggressive, and I would be more tempted to remove it because there's more likely to be soft tissue stripping. And another thing you mentioned last week with open fractures is that there's actually plenty of evidence that using local antibiotics is effective as a means of treating these types of injury. And the one that we've tended to use is something called stimulant calcium sulfate, which you can leave inside the soft tissues, and it just dissolves over 6 weeks and releases the antibiotics that you put inside it. So here's an wound, and about 12 centimeters long, the whole track of this wound, and that's why we've got such a small exit wound. Can you hear me, Raheel?
Yes, you were breaking up initially, but we can hear you now. Carry on, Amer. Okay, we seem to have lost Amer there. I'm just going to message him, and then we can carry on with this. I'll carry on. So the question we have is, so as Amer has said, we extend, we debride, and we lavage the wound and then stabilize with an external fixator. And here's the amount of dead bone that was fished out of this case before the X-Fix was applied. Amer, can you hear us? Okay, so I was just talking to the audience about the amount of dead bone that was excised in this.
We've followed sort of that same sort of extend the wound, as you said, for open fractures, excise the wound, lavage it, and amount of the bone floating around.
So obviously the message which is coming across is that it's an open fracture, but you've got to be far more aggressive with these and pull out bits of bone which might have a tenuous hold on soft tissue. There is a possibility, there is a distinct possibility that these bones will shorten.
Yeah.
And we'll look later at how
but that's just one example. Now we're going to talk about blast injuries.
Mm-hmm.
So as I've said, we have had a blast injury in Manchester and elsewhere, and there are different ways that we blast. Depends on the mechanism that's involved in causing the injury. So we talk about primary blast injury, secondary, tertiary, and quaternary. So let's move forwards. And I just want to give you an idea of what it looks like when a bomb falls. And I want you to remember that with this particular type of bomb, this is actually quite an amateurish bomb because it's made by a barrel with TNT and also with nails and bolts and bits of loose metal. And this is a barrel bomb, which is very typical.
So I'm seeing the video as we go along. We've lost your screen, but we're seeing the video. It's very
Russian helicopter. And the Russians have actually refined the barrel bombs by putting tail fins on them, which makes them spin in the air and makes them a bit more stable and a bit easier to aim. But it's still a very crude device. And you know, if you think about the bombs which are professionally bombs and munitions that are being dropped, they are far, far worse because they are engineered to cause maximum harm. So let's move back to the presentation. Okay.
Yeah.
And so what happens when a bomb explodes is that it's a chemical reaction. It produces vast amounts of heat and gas, and that gas will expand. And when it first expands, it expands so quickly, it actually sends off a supersonic shockwave. And that shockwave is moving outwards incredibly quickly at like 3 to 9 kilometers a second. You know, it's hard to conceive of just how quick those blast waves are moving. And what it tends to do is cause damage in hollow organs, so where there's a junction between a solid and an air-filled organ, and it's the interfaces where there's most injury. So if we move to the next, will show us a blast wave.
The video?
It's actually from the BBC. It's the BBC slow motion video.
We're going, which video are we going?
And in slow motion, it's actually possible to make out this blast wave. Now, anybody who's watched the explosion in Beirut will have seen the same kind of thing. So if you look very carefully, although you can see the gases exploding and expanding, you can see that there's a clear film, and that's the shock wave moving outwards much quicker than the gases, and that's moving, you know, between 3 and 9 kilometers per second, which is absolutely phenomenal. So we'll go back to the presentation again.
Just to give you a sense of the damage. So just to give you a sense of the damage at the bomb site, at the epicenter, you've got 16 million psi pressures going through a pound inch, square inch. And it just takes 60, not 16 million, 60 psi to cause a fatal injury. So it's a phenomenal amount of
this shockwave can cause injuries that you can't even see. So what we know from the Manchester bombing is that we saw people who had neurological injuries who had normal MRI scans, but they still had the signs and symptoms of a stroke, and that was basically caused by the shockwave damaging the brain. Similarly, you can get shockwave resulting in gas formation within the abdomen. It doesn't mean that there's been a perforation, but you can find gas. So as well as that, we've got secondary blast injury. Now, the pieces of metal that you can see there in the top two pictures, these are what we call improvised shrapnel. So if you have ever seen a grenade, you can see that it's designed to fragment and produce pieces of metal, you know, moving away from the explosion at very high speeds to cause damage. With this type of shrapnel, where it's improvised, they're just everyday objects which have been packed around explosive. So the top picture is just a simple nut, and the middle picture is what we might call incidental shrapnel. So it's a piece, might be a zipper from clothing or from a bag. And then at the bottom, we can see a little piece of bone. And what can happen is that those people who are closest to the explosion, sometimes it's possible that people's bodies are disintegrated and their bodies are then propelled outwards from the site of the explosion at very high speed, and their bone can then penetrate other people and be a type of biological shrapnel.
So, Amer, just to sort of clarify for the audience, the primary blast injury is
That's
the
right.
injury that occurs due to this massive supersonic wave, correct? That causes collapse of organs.
It's
and
from
all sorts. The secondary blast injury is,
or parts of people being blown apart from the center of the explosion and penetrating other people's bodies.
okay, so actually parts of the bomb or parts of
Right,
shrapnel,
okay.
like nuts and bolts and things like that, which penetrate other people.
So let's ask a question. We've talked already about how these are contaminated injuries. So let's have a poll. What's the best way to give antibiotics for these open wounds and open fractures?
Okay, so we've got a large number of audience who's clocking in,
Okay.
going both for intravenous
We'll
and
just
local
give a few more
antibiotics.
seconds for people to answer.
I think, yeah. So would you do anything different with antibiotics in a standard box standard open fracture versus a ballistic injury, with the duration of antibiotics given following definitive fixation?
At last
and
week,
closure?
when we talked about open fractures, there's very clear evidence is effective, and it gives you much higher doses at the site where you want it to be compared to intravenous antibiotics alone. But because there's that 10% of contamination that might have traveled down tissue planes and we might not be able to access locally, I think it's a good idea to give intravenous antibiotics if you can, as well as local antibiotics. And that's what the UK guidelines are.
So how long would you continue intravenous antibiotics
That's
once you've
again a
covered the wound
controversial area.
after fixation?
We're not really sure about what the right timing is. Certainly, I think it's worth continuing intravenous antibiotics for 2 weeks and then perhaps converting to oral antibiotics for another 4 weeks, but giving a good 6-week course of antibiotics. So tertiary blast injury is caused by effectively the blast winds. So if you can imagine the speed in a hurricane might be up to about 300 miles per hour. The speed of the blast winds from an explosion, especially high explosive, can be 10 times as much as that hurricane, 1,000 miles an hour in a small area close to the explosion itself. Now, this isn't something that we saw in the Manchester bomb, but that might be because the bomb was too small, or the people who suffered the tertiary blast injuries were all the ones who were close to the bomb and they were killed. And there may be multiple reasons why we didn't see it, but it's something that I have seen in bombings, especially in Syria, and it's something that really haunts me even now. It's one of the most horrific things that I've ever seen, and it is amazing what one human being is capable of doing to another human being.
So the tertiary blast injury is when people are flung and they hit pillars or
That's
posts.
Right. So it's basically caused by the blast wind. So it's either
that blunt injury,
picking people up in the blast wind and blowing them, either removing parts of their body or blowing them into other structures, or knocking down structures and they then fall down and cause crush injuries. And then there are what's described as quaternary blast injuries, which are other types of problem which may occur as a direct result of the bomb, but are not to do with the bomb fragments themselves. So if burns are caused, if there's crush injury, if there's inhalation of noxious gases, or if it stimulates angina or asthma attacks, then that's known as a quaternary blast injury. So one thing, this is an interesting question, of all the people who are going to be involved after a bombing, which surgical department is going to see the most casualties? So I would hope that everyone's interested, who's going to be the busiest?
So we'll give them a chance. We're all orthopedic surgeons here, so there seems to be a general bias towards orthopedic surgery. So if we had to talk through that, thinking aloud, we'll give a few more moments for the audience. But most of the people who have
I can hear you fine. Yeah, carry on.
Amer, can you hear us? Okay. So do you reckon cardiothoracic sees the least? Because most people who have a blown up aorta.
Yeah. So the chances are actually that if you have an injury with shrapnel to the head or the abdomen or the chest, you're probably less likely to survive. So everybody's given their answer now.
Yeah.
And
yeah, we've got 57%. The majority have gone with orthopedic surgery. It's a close call, and 43%.
So this is the evidence. So this is from the Journal of Royal Army Medical Corps, looking at who survives. So who's going to survive after they've had a penetrating trauma. And what this graph shows that this is something that hasn't changed. If you have an injury to your head or your chest or your abdomen, you are much more likely to die. The ones who survive, ones actually.
So Amer, we seem to be losing your audio for a moment there. I'm just going to reiterate that point you've made, that that most people who have a head, chest, or a neck injury or an abdominal injury don't make it, they don't survive. So the answer to that would be that the orthopedic surgeons see the most of the trauma, because the limb injuries are the ones which survive and tend to come into hospital before they bleed out.
So orthopedic surgeons should expect to be busy after a bombing. So here's an example of a patient who's been injured, and there's improvised shrapnel, and what you can see all around the body there are little lumps of metal, and these lumps of metal are nuts and bolts which were packed around explosive. So there's an open femoral fracture, so that the metals hit the bone and it's transferred energy to the bone and caused a fracture in the femur and the tibia and the hands. And for patients who are injured in this way, we need to get a top-to-toe CT scan, because that's the best way of identifying where all the injuries are. We're going to talk about damage control in a few weeks' time, but damage control surgery is the way that you're going to try to treat as many patients as you can in the shortest possible time. So for the bone injuries, we want to stabilize them by using monolateral external fixation. So we've stabilized the long bones, which will also stabilize the soft tissues. We're going to debride the soft tissues, and we're going to use our local antibiotics as we described before. For definitive treatment, we've moved from the monolateral external fixator to an Elizaroff type of fixator, which will allow our patient to weight bear. And it also, we've spanned the knee, but we haven't actually stop the knee from moving. So hopefully we can allow the knee to carry on mobilizing. We've managed the infection by putting in local antibiotics, and they've had a gastroc flap and a split skin graft over the top to manage the soft tissue defect. Now, there was some bony injury, and this has been treated with shortening of the bone. So the parts of the bone which were not viable have all been removed. And if you have a look on the left, you can see how much damage here. And if you look progressively to the right, you'll see that we've removed all the loose bits of bone so that it has a better chance of healing. So there's more bone to bone. Left-hand picture, granules of antibiotic pellets that we've put in to the fracture as well. Here's another.
So I just want to focus the attention. You may have mentioned it, but so if you just go back to the previous slide about how you flattened out the proximal end of the tibia in that intraoperative.
Okay, so basically the problem was that there were big spikes of bone, and if those big spikes come together, then we're actually getting very little bone contact. But by flattening the ends, we then actually get a lot of bone contact, and that gives us a much better chance of healing. And I'm pleased that, you know, in this case, that was a successful tactic. So it's managed to get the bone to heal, and we can be confident that we can stretch the bone later to get the patient's bone length back. But you know, in the short term, it's far better for the patient to have all that dead bone or that non-viable. Here's another case, so another open tibial fracture, and you can see on the left-hand picture all those little grey circles which are in the soft tissues, and that's protecting the bone, and it's protecting the soft tissue flap which is overlying it. So we're getting delivery of antibiotics for 6 weeks after we've closed the wound. And this is the patient himself. This is from his Instagram account, and you can see him with 2 external fixators.
He's got accessories there.
Yeah, so
fixators
plastic surgeon from Manchester, Jason Wong, who you and I both know, who spent a week with us at Manchester Royal Infirmary, these patients together, and it was very successful, I believe. Now, I'm going to give you a few examples about why I'm not so keen on internal fixation for these types of ballistic injuries, and that's because, unfortunately, in the Syrian conflict, I've seen far too many people who've had internal fixation, and unfortunately, it's resulted in the patient suffering a lot more, because if you look at the far right picture, you can see this is a tibial plate which would normally be used for a tibial plateau fracture, and unfortunately the skin has broken down because it's infected, and you can see dead bone at the front of the tibia as well. Now, in the middle picture, you can see a plate which is
Amer, you're still there? We seem to have lost you for a moment. I'm just pushing a poll to the audience while we get Amer back. I'm just going to message him. So it's okay for Amer to say. It's okay for Amer to say he's going to put a circular frame on, but a lot of us may not be comfortable putting a circular frame on. So in the real world, when you're in a disaster zone or you're a military surgeon who's possibly in a far-off area, we are left with what we have. So how many of you would be our internal fixators, and how many of you are external fixators here? I'll give you a moment to answer that question, and I'm just going to message Amer as we of the audience who'd go with an external fixator. I think that's a wise option, but we need to understand that not all of us are comfortable with external fixators, and it's probably wise to refer it on to people who are used to managing these complex injuries. I'm just going to carry on with the presentation until Amer joins us. So these are obviously the complications that we see. Amer, are you back on?
Raheel?
Yes, we can hear you now.
Okay,
I just moved one slide whilst we were waiting.
So the point I was trying to make was that if you put on a monolateral external fixator, then it's possible to temporize it, and you can then, the patient can travel and wait until they've had more the possibility for definitive surgery. But if you put an internal fixation and they're getting...
We were just discussing there. We were just discussing the option of internal fixation versus external fixation, and I pushed a poll to the audience there, because quite a large number will not be comfortable using circular frames. So is there a role for monolateral or biplanar external fixators to treat these definitively?
As a temporizing measure, so that you can get the patient to a place where they can have more definitive treatment?
No, as a definitive measure in places where people might not be comfortable using a circular frame, and they're in a war zone in the middle of nowhere. In that instance, would we go with an internal fixation, or would we go with an external fixation option with possibly a biplanar?
I would always prefer the external fixator, just because it means that there's less risk of causing more harm to the patient. Okay, so in this slide, this little girl is 9 years old. She's the same age as my daughter, and it was very difficult for me to try to treat her because of the very severe injuries that she'd had. And I think there was a role for her to have an external fixation for. So I've seen, unfortunately, a lot of complications because of the use of internal fixation, and it may be that I'm just seeing a small minority, but unfortunately it's enough to cloud my judgment. So here again is another patient who's had a lot of internal fixation, and there's not really very much bone left around his elbow for anything to be done in the future. So I think we're not able to help in this case. As well as all those surgical issues, there are other non-surgical issues that we need to think about. So if there's been biological shrapnel, then we need to think, well, is there a risk that the patient could have been inoculated with hepatitis or HIV or any other disease? So patients need to have some kind of immunization. There's a risk of having injury to a patient's hearing, and that might be something that's immediately apparent, or it may be something that summary. safely say that ballistic injury is not clean. You shouldn't be closing wounds at the first sitting. You need to debride these wounds pretty aggressively. My advice is avoid internal fixation if you can. Having had experience from several conflicts that putting metalwork near a potentially contaminated wound is just a recipe for disaster. I personally would always go for a circular fixator because that's, you know, my practice.
Thank you, Mr. Shoaib. Thank you, Amer, for a very enlightening 30 minutes. Unfortunately, the audio was a little poor but, on occasions, but I think we all got the gist of the message there. We're going to move on to a couple of quick cases just to spice things up a little here. As Amer was talking about ballistics and blasts, we're going to go with this one. This is a 33-year-old man shot in the street by a shotgun and a wound on his left thigh. So here's the question. What are our priorities for treatment? Which is the top priority? Is it breathing? Is it circulation or the airway? We'd like you to answer that question. So the vast majority have gone with airway there.
All right, so if you've got somebody who has a penetrating injury, especially in war, actually it's the risk of bleeding is the biggest cause of death. And generally, if they've got an airway injury, there's not much you're going to be able to do about it. Or if they've got a chest injury, you may not be able to do very much. If they've got a circulation injury and they're bleeding out, that actually is the one time where you might be able to make an intervention that could help. So instead of going for an ABC approach, in this, for penetrating injuries in war especially, it's worth going for a CABC approach and trying to arrest bleeding by putting on a tourniquet or by using direct pressure or using hemostatic agents in order to try to control the bleeding. And then, because that's a fairly rapid treatment, you can then, if you put on a tourniquet, it should take you maybe 20 seconds, and then you can go back to look at airways and then breathing, and then circulation again.
Correct. So the vast majority, 92%, have gone with airway. But what we want to reiterate to you with this is that it's a CABC approach. So look at circulation first, then go to airway, breathing, and then come back to circulation. And the difference between an open fracture management versus a gunshot or a ballistic injury with an open fracture is that the use of tourniquets is used far more liberally in gunshot injuries and ballistics. And that's one of the most important factors that has reduced fatality from ballistic injuries, the use of tourniquets, which we don't advocate in open fractures because we use direct pressure first, all sorts of tamponade, and go for tourniquet right at the end. That's your last resort in a box standard open fracture. Okay, so this patient, this is the X-ray. He is hemodynamically stable. He's got an isolated injury to his leg, and this is his X-ray. His left femur has a butterfly comminuted fragment and a fracture to the midshaft with lots of scatter from the shrapnel. So what are the injuries that we're worried about? Is it a nerve injury? Is it vessel? Is it compartment syndrome? Is it fractures, or all of the above? So we'll go back to that X-ray. It's pretty much in the center of the femur. You can see a few scattered bits of lead in the pelvis. So 70%, we've got a few more who we're waiting to answer. The vast majority, it's a bit of a, well, 40% seem to think it's the blood vessel which is at risk here. And 62% say all of the above. I think the right answer here is all of the above, because you've got to be worried about pretty much everything: a nerve, the vessel, the compartment syndrome, and the fracture. As a side point, a mangled extremity is a descriptive term, but a mangled extremity actually is when 3 out of the 4 structures are damaged, whether it's nerve, vessel, the bone, or the soft tissue. So if any 3 of those are damaged, that's called a mangled extremity. That's how we define it. So the vast majority seem to have got all of the above right. While we move on, he has no bleeding. There's no, vascular injury on the angio. There is no nerve injury. He does not have compartment syndrome. And now we're looking to manage the bony injury. So as we discussed, extend, deliver the bone ends, debride, lavage, and stabilize with an external fixator. What are we going to do with that bone that is shattered? So we'd like you to answer this question. Excise it only and lavage, add bone graft to the area, excise the bone, and add antibiotic beads to the wound and fill the gap. Amer, I know you've mentioned in your talk what we should be doing. Let's see what, well, that's pretty comprehensive. 100% so far are going with excising the bone, adding antibiotic beads, and
I feel very satisfied that this is a big take-home message, and I'm really pleased that everybody has taken this on board now. That that's what we need to be doing. Excising it and lavaging it is one thing, but we need to stabilize it, and we know from the literature that antibiotic beads help to decrease the risk of contamination, and they deliver much higher doses of antibiotics locally than you would get from systemic administration.
Absolutely, yeah. So we discussed this last week, where the risk of osteomyelitis is reduced to about 6 to 7% in these kinds of injuries when you have local antibiotic delivery, versus close to 25 to 30% through systemic antibiotics. Okay, so here's another question for you. How are you going to fill that bony defect? Are you going to bone graft it? Are you going to use the mascale technique? For those of you who aren't familiar with the mascale, it's where we debride and we fill the gap with some cement and allow a living biological membrane to form around it. Then we go back later, open up that membrane, take out the cement and pack it with bone graft. Or are we going to bone transport with Ilizarov with an acute shortening? So those are your options. We're going to give you a couple of moments to take your time.
And there is no right answer. Again, there are different opinions. People would do different things, and it's useful for us to be able to gauge how people think about this. But so long as you can think about plan logically, of opinion. So there are people who.
So we're going to.
So there's still a few people who haven't chosen any answer. If you can try and do that for us now. Just a few left. Okay, so what do you think, Raheel? In terms of the options, what's a safe option for a patient?
So I think more than one option is safe here. So that's the first thing to point out. I think mascale is an entirely reasonable technique. You could possibly pack some antibiotic impregnated cement in there to locally elute whilst that membrane is forming. Bone transport with Ilizarov, obviously doable. Acute shortening and then staged lengthening is another option. I would probably go with, sorry. So let's see what the audience has gone with. 38% have gone with bone transport with Ilizarov, and 30% have gone with acute shortening. So I think either of those it's essentially what works best in your hands, what you're comfortable doing. I've been comfortable with the mascale because that's how I've been trained. So I would probably slap a frame on and put some antibiotic loaded cement in there and come back later and bone graft it with via mascale. But I know that bone transport or acute shortening and gradual lengthening at a second stage is perfectly reasonable. Let's see what you did in there.
So he's had the Ilizarov treatment, and what you can see is that at the bottom is because we've moved that segment of bone upwards, we've done an osteotomy and we've grown about 5 centimeters of new bone, and more proximally you can see that we've brought the ends of the bones together, and that's actually nicely united now, so that it's safe to remove the frame because the bone's nice and mature. But unfortunately,
so did you do a huge shortening, staged lengthening, or did you do both of them at the same
sorry,
time?
could you say that again?
So did you acutely shorten it and then go back later and do that distal femoral osteotomy, corticotomy to lengthen, or did you do it all in one
I actually left a gap, and then we moved that segment of bone. So as we were putting the bone distally, it was also compressing it proximally as well. Yes.
Sure.
Yeah.
So
but
transport, okay.
This patient's had multiple infections, because every single one of those little metal balls is capable of that infective focus. So several times he's come back to us, even though his bone is healed up, he's come back to us because he's had some small areas of soft tissue infection as well.
Okay, it looks really good there. It's had good consolidation. So here's the final one. So he's had that treatment, and now the knee is quite difficult to flex and extend passively. How can we improve the flexion? Physio, lengthen the quadriceps, nothing. The muscle is far too damaged and scarred to do anything, or release the muscle from the bone. So this is an interesting one. I'm not sure a lot of the audience will have had an exposure or experience with this. Let's see what they come up with. Okay, so we've had a bit of a split here. We've got 40%. So lengthening the quadriceps and releasing the muscle from the bone seem to be the most popular answers. And physio. Well, there's almost a three-way split between those: physical therapy, lengthening the quadriceps, and releasing the muscle from the bone. So for those who aren't familiar with lengthening the quadriceps, it's quadriceps plasty, which is quite a technically challenging and demanding procedure, particularly in patients like so, where there's a lot of scarring and the quads are stuck down to the femur. What would you do, Amer?
What I'd be worried about with lengthening the quadriceps is that although it might allow the knee to flex more, and the quadriceps themselves may not be doing very much, because there's the problem is that they're scarred down, so they're really glued down to the femur because there's been so much trauma, and it's possible to, if we can release the muscle from that being scarred down to the bone, that it would actually allow the muscle to glide more smoothly and to gradually allow greater knee movement with physiotherapy. But there's no right answer here. I think that physiotherapy always has an important part, with or without surgery. I think it's possible that lengthening the quadriceps might work, and it's possible that just a muscle release might be enough, or it might be a combination of different treatments. What would you do?
And I think it's really, I agree with you, with whatever surgical intervention we do, I think the surgery is probably just half the battle. One, the crucial thing would be to have a CPM machine immediately post-op for a few days to actually get that muscle moving.
I think that's the last slide, isn't it?
Okay. Yeah, that's the last slide from that. Do we have time for one more? We're going to go with one more case before we call it a day. And we're going to give you about 5 minutes for any questions, 5-10 minutes if you have any burning questions to answer those. Here is our case 2. Okay, so here's a 38-year-old man at home in his apartment when a bomb went off close by, and he came in with an injury. His left arm has been avulsed. He has a penetrating chest injury, as you can see in that X-ray there, but he is breathing. Now, what are your priorities? Let's see whether we've got our message driven home. Stop the bleeding, check the airway, assess his chest. So we've got a few more left to answer between those three, but as we've discussed with ballistic injuries, the priority always is to stop the bleeding, not the airway. It's a modified approach to the ATLS where it's CABC, because the patient might have catastrophic bleeding, and before you've even gotten to the airway, he's bled out. So the priority is just get that bleeding stemmed and then move on to the airway. And the vast 70% seem to agree with that there. That's the principle for that. Okay, so his bleeding has been stemmed with C-locks and direct pressure. So as we said, it's a CABC approach, and the ABCs are stable. He's got no pneumothorax despite that shrapnel piece lodged in his chest. And now
Raheel, do you think it's worth talking about what C-locks is? So people may not have come across C-locks, but C-locks it's made from a chemical which is derived from fish, and what it can do is it causes blood to coagulate, even in somebody who's on warfarin, or if it's cold, it will still cause the blood to coagulate more quickly. So if you use C-locks directly on a wound, and what we normally do is have a roll of gauze which is impregnated with C-locks, and we jam that into the wound to try and get that to bleed. Then we put direct pressure over the top. And in this case, there's no room to put on a tourniquet, but if there was more of the arm left, then you would put on a tourniquet as well to try and stem the bleeding.
Thank you. Okay, so here he is in the operating room now. He needs a through shoulder amputation. The question we've got for you is, how much of that muscle which is visible should be debrided? And your options are: preserve all of the deltoid seen to make a flap so the joint is covered, excise anything that is damaged, and leave the wound open for reinspection in 48 hours, or remove all the shoulder muscles, chop them all off, and let the plastic surgeons fill the gap later. So we've got that poll running. We've got a few people who've answered. So Amer, if you want to give us some practical tips on when we're debriding with ballistic or blast injuries, how do you know what muscle is viable, what soft tissue is viable? Besides the fact that some of it won't be bleeding, that's obvious. But when you've got that doubt, that gray area, how do you identify which bits we take out?
Essentially, what you're going to do is look at the macroscopic appearance of the muscle. So if it looks like a steak that you might buy in the butcher, and it looks beautiful and pristine, then that muscle is healthy, it's not been damaged, and that's worth retaining. If it's all straggly and there are bits, and it looks like a raw muscle, then that is not viable and it needs to be removed.
We lost it there for a moment. You want to just repeat that? If it looks scraggly, I think what you're trying to allude is if it looks like a hamburger, as you normally say, or
absolutely.
Minced meat,
so if it looks like a mincemeat, then you're going to remove it. If it looks like it's steak, like it's pristine, then that's actually healthy, and you want to try and retain that to get your soft tissue coverage.
Okay, so coming back to our question, excise anything that is damaged and leave the wound for reinspection in 48 hours seems to have had the bulk of the answers.
I think we'd agree with that, wouldn't we?
That's probably right. Yeah, we would agree with that. Okay. So we've got one final case we can quickly run through and then leave the floor open for questions if people have any.
Well, I think we've done that one already, haven't we?
We discussed this one.
I think that probably was the last case, wasn't it?
Yeah, case 3. Okay.
I think we've done that one already.
Is it? Yes. Okay. So yeah, we're done with the cases. So I'd like to open the floor to the audience for any questions you might have. Please post them in the chat, and if you want to make a point, we'll open up the microphone for you as well. Does anyone have any questions? We'll give you a moment. Whilst we're waiting for any questions, Amer, what is the do you think there's a big role for vitamin D. We talk about vitamin D a lot. We talk about vitamin C and albumin a lot as supplements. Do you think there's a role for any of these in blast injuries, or any supplemental biologics we might be able to use?
To be honest, I haven't read anything like it's still an evolving. There are lots of things that we don't know yet. Whether
we seem to be losing some of your audio while we're waiting for Amer to pitch back in. We've got a question from Ayman. Do we apply local antibiotics at first session of debridement only? The answer, Ayman, is no. You apply at the first session. When you go back in and you think it's not closable, you can put the antibiotic beads back in again. And sometimes if you've got a defect which you just want to close and cover and then come back and like the masculine technique, you can leave antibiotics in for about 4 to 6 weeks. So you can leave local antibiotic beads even after definitive stabilization, just to allow them to elute locally gradually over 6 to 8 weeks.
Yeah.
So I hope that's answered your question. If it has, please just type in yes.
Yeah, can you hear me?
Amer, are you back on?
Yeah. So I mean, when you put in local antibiotics, even though it's going to last 6 weeks, you know, when you debride again, you're probably going to clear out what you've put in the first time and put some fresh antibiotics in anyway.
Yeah. Okay. Do we have any further questions? So, Amer, just to summarize, top 3 take-home messages for ballistic injuries.
I think, please
lay it out for us.
All ballistic wounds are contaminated until proven otherwise. Number 2, don't close wounds at the first sitting. And probably number 3, try to avoid internal fixation and use external fixation, especially at your first operation, so that you're spanning the bone and stabilizing it without causing any further soft tissue disruption around the fracture site and the wound site.
There you have it. 3 top take-home tips from Amer Shoaib. I hope you found this session useful. It's fascinating to see these quite nasty injuries and how we deal with them on an evidence-based manner in a stepwise algorithm. If you're interested to have any further information, please contact us. We're more than happy to answer your questions. And next week, we're going to be discussing compartment syndrome. And the following week, we'll have damage control orthopedics to sort of round off our trauma theme for the month. The following month, we'll be doing some foot and ankle, and then we'll be taking it each joint month after month. So hopefully, if you've got any feedback, please do let us know. But I hope you've enjoyed your session and learned a lot.
Thanks, Raheel, and thanks to everybody for attending the webinar.
Okay. Take care, everyone. Goodbye.